or is it meant only for lupin technical team? It's purely a lupin technical team, or
Yes.
you?
No, sir. We actually arrange for Cipla, Sun Pharma, and Alembic, and so on.
Oh, yeah. So you are in general arranging for multiple pharmaceutical companies also.
Yes, that's why we need huge team.
Yes. You are stationed in your headquarters is in Mumbai, is it?
We actually based on Surat. The
Okay.
company was established in Surat, then moved to the Mumbai for marketing. Our one office in Mumbai, and the main office which we are doing the technical things and arranging the webinars, organizing the webinars, is in Surat.
Oh, so your main office is in Surat, but you have got
Yes.
the.
Yes.
Okay, I think we can start because.
Okay, sir. So after my countdown, we can start.
Yeah. Okay, you can start your countdown.
So it's 3, 2, 1. Over to you, sir.
Thank you. Okay, good evening, students. Today we will continue with the analysis of some more hemodynamic data so that you are quite confident in analyzing these data. And once we analyzed about 10 or 15 cases, it becomes easy for you to look at any hemodynamic data. It will give you a lot of confidence. And once you are confident enough to interpret, then everything becomes very easy. It is a lack of confidence which creates problems. Okay, so we'll start with the first one. Can you see my screen?
Yes, sir.
Okay. So is that Egnath?
Yeah, it is
Yes,
in a
sir.
full screen mode.
Okay. Okay. Any volunteers to discuss the data? Anybody who would like to volunteer to discuss the data, the pressure data as well as the oximetry data? Egnath, why can't you try? I will help you so that you can gain confidence.
Yes, sir. Right.
Okay, right. Yes, start.
Actually, I am not that much. You know.
You are not?
Yes, sir. I am not that much. This hemodynamic data is very. I am very poor in that this areas. Like,
You are not confident. No, I think the idea of these discussions are to give confidence to students to look at any hemodynamic data or anything for that matter and gain confidence in the examination also. So it does not matter. See, if you knew everything and if you are very confident about everything, then there is no more training. So training is to bring up the standard of a student who is not confident enough to interpret maybe hemodynamic data, maybe his electrocardiogram, maybe pressure tracing, maybe clinical findings. So a lot of things are there for the student to get trained. So here is one session that is on hemodynamic data. Okay, we'll start. Because I don't think you were there last class, so I think we'll ask somebody who was present in the last class to start the discussion. The next case you can discuss. Anybody who was present during the last class, would you like to discuss the case? Bensi, were you there in the last class?
Yes, sir. First, oximetry data. Left innominate vein 64%. Lower limb innominate vein left 92%.
Not lower limb, actually it is left lower innominate vein. Actually, it is left, there was a misprint there. It is left innominate vein, low level, low innominate vein, higher is high level.
Okay. And it's high 92%.
Okay. So what does that mean?
There is mixing of the there is step up
Yes, there is a significant step up at the
level of left innominate vein.
lower part of the left innominate vein.
Innominate vein.
So what is the situation where there can be a so significant step up in the innominate vein?
TAPVC.
Yes, TAPVC. Of the which variety? Is it the supracardiac, cardiac, or the infracardiac variety?
Infracardiac.
Innominate vein step up is in infracardiac variety.
No, sir. Don't know, sir.
Well, in a supracardiac variety, where does the anomalous venous drainage join? Where does it join?
Into the common common vein which go into the left SVC.
Yes. No, not the left SVC. It joins the. It may join the left innominate vein, or it may join the SVC at the region where the innominate vein opens into the SVC.
SVC.
Okay. In the cardiac variety, where does the pulmonary veins join? Where does it drain? What is the pattern of drainage when you are thinking of a cardiac variety of total anomalous pulmonary venous drainage? Anybody would like to give an answer?
The vertical vein?
Yes, vertical vein is the one which is the common pulmonary vein, which goes up, joins the innominate vein, or maybe at the junction of the innominate vein with the SVC, but that is the supracardiac variety. But in the cardiac variety, where does it join?
The coronary sinus.
Oh, very good. It joins the coronary sinus. And infracardiac variety?
Sir, IVC.
IVC, yeah. So these are the three areas where usually the anomalous pulmonary veins drain into the superior vena cava, into the coronary sinus, and into the IVC. Thereby, it can be supracardiac, cardiac, or infracardiac variety of total anomalous pulmonary venous drainage. Here it is. We have found that there is a significant step up at the lower left innominate vein, indicating that we have to think of a possibility of total anomalous pulmonary venous drainage into the innominate vein, which is a supracardiac variety of anomalous pulmonary venous drainage. Okay, yes, go ahead. Bensi, go ahead.
Yes, the high SVC 92%, low SVC 91%. There are significant step up, but there is.
There is no step up there. The step up was at the lower innominate vein.
Yes, sir.
Okay.
IVC 66%. 88%. There is step up at the level of right atrium.
Why did you say there is a step up at right atrial level?
It's coming from the SVC only.
Oh, yes, you see, this SVC and IVC come together and drain into right atrium. So already the step up has happened in the SVC or into the innominate vein. So the further there is no step up at the right atrial level. Actually, the right atrial oxygen saturation is less than what is in the SVC.
High
SVC. That is because the IVC, which is only 66%, is draining into right atrium, and when the blood mixes up, there is a drop in the right atrial oxygen saturation compared to the SVC oxygen saturation. Okay.
Okay, sir. Then right ventricle 87%. Okay, pulmonary artery 88%. Normal pulmonary artery wedge 100% is normal. Left atrium 87%. There is step down at the level of left atrium and left ventricle 86%. Aortic 85%.
Okay.
So it's cyanotic heart disease.
There is a desaturation at the in the systemic circulation. So it is a cyanotic problem. Okay, right? Yes.
TAPVC, supracardiac variety of TAPVC.
Yeah, from the oximetry data, you think there is a supracardiac variety of TAPVC because there has been a good step up at the
left lower innominate vein and high SVC.
Okay, so but on this data alone, you cannot say that it is a supracardiac variety of total anomalous pulmonary venous drainage. Do you have any other data in the oximetry to tell that this could be a total anomalous pulmonary venous drainage?
The left atrium is 87%. So there is step down at the level of left atrium and pulmonary artery wedge is 100%.
A step down in left atrium is normally the pulmonary from the pulmonary wedge that drains through the pulmonary veins into the left atrium. But here the drainage is not that way. But from the oximetric data, what are the points which tell you that this could be a total anomalous pulmonary venous drainage?
Saturations everywhere are equal.
Yes, saturation in all the four chambers are practically the same. RA is 88, RV is 87, PA this left atrium is 87, left ventricle is 86. All are almost equal. That's 1 point. 2. Any other point? Saroj, would you like to give a comment?
Yes, sir. Yes, sir.
High innominate vein is normal, 64% normal.
Which one?
High innominate vein.
That only means that the oxygenated blood has joined the innominate vein in the lower part, not in the higher level. So that will not tell you that it is total anomalous pulmonary venous drainage. What is the oxygen saturation in PA? What is the oxygen saturation in aorta?
Yes, sir. PA is more and the aorta is less.
Yes.
That's why, sir, it is total anomalous.
Yes.
Right side is more.
Yeah. So now, so when the PA oxygen saturation is more than that of the aortic saturation, what are the conditions where it can happen?
So one is transposition physiology.
Very good.
Sir, so transposition, sir, can be at the level of pulmonary vein. Like, sir, here, which we are seeing that the pulmonary veins are draining into the right side of the heart.
Okay.
And sir, then, sir, transposition can be, sir, at the level of the great arteries.
There are only when you are finding that the pulmonary artery oxygen saturation is more than that of the aorta, you have to think of only 3 conditions. One is the supracardiac variety of total anomalous pulmonary venous drainage, transposition of great arteries, and third one, toxic being anomaly. In toxic being anomaly, also you can get a pulmonary artery oxygen saturation more than that of the aortic saturation. Why it is that in patients with supracardiac variety of total anomalous pulmonary venous drainage, you get oxygen saturation in PA more than that of the aorta, while in cardiac or infracardiac variety it does not happen. What may be the reason? Explanation?
Sir, in case of TAPVC, sir, there has to be a, sir, communication. And sir, there is a, sir, right to left to shunt and sir, drainage of the veins from the no sir no. LA.
No, there has to be a communication from RA blood test to there should be a ASD is a must in these patients.
Yes,
Otherwise, the child cannot survive.
Yes,
So
yes,
there's a large ASD and the blood flows into the left atrium from the right atrium.
From the right atrium.
That happens. But
Yes,
it is usually in supracardiac variety that you get oxygen saturation more than that in pulmonary artery, more than that in the aorta. While that does not happen usually in the cardiac where it drains into the coronary sinus, or in the infracardiac where it drains into the IVC. So what is the explanation?
Sir, there is a favorable stream, means infracardiac variety, the blood will come and through ASD, it will go to the left side. But in case of supracardiac, the direction of blood is towards the tricuspid wall. It will more go to the RV and then to pulmonary artery, sir. That's why.
You are almost right. When you look at the venous drainage, the blood draining from the superior vena cava usually drains into the right ventricle. And there is a large AST and there is a shunting of the blood from the right atrium into the left atrium. Then the blood draining from the IVC has got a tendency to flow towards the secundum ASD and it drains into the left atrium. So the blood coming from the IVC is less oxygenated, or rather it is deoxygenated blood, while the one which is coming from the superior vena cava is more oxygenated because it mixes with the oxygenated blood. So more oxygenated blood flows into the right ventricle, while there is a tendency for more deoxygenated blood which is coming from the IVC to flow across the intra-atrial septum into the left atrium and into left ventricle. Because of that, in supracardiac variety of total anomalous pulmonary venous drainage, there is a higher oxygen saturation in the pulmonary artery compared to the aorta. But it does not happen in cardiac variety because the blood draining through the superior vena, through the pulmonary, through the coronary sinus actually gets mixed up in the right atrium, and there is no streaming of blood through the from the either from the superior vena cava or inferior vena cava to the left atrium. Because of that, the oxygen saturation need not be higher in pulmonary artery compared to aorta. The same thing happens with the IVC also. IVC drainage also, where more oxygenated blood can actually drain into the left atrium and left ventricle, and sometimes you may get more oxygenated blood in the pulmonary aorta than in the pulmonary artery. But then very often the infracardiac variety of total anomalous pulmonary venous drainage is usually associated with significant obstruction, and these patients can have pulmonary edema, and so their hemodynamics is significantly different from the supracardiac variety, where the obstruction is not very significant and the child can actually survive. So in supracardiac variety of total anomalous pulmonary venous drainage, you may find that the PA oxygen saturation is more than the aortic oxygen saturation. This is because of the streaming of the blood, where the blood draining from the superior vena cava, where to which the vertical vein and the combined pulmonary veins drain, actually is streamed towards the right ventricle, while the blood coming from the IVC is streamed towards the ostium secundum, through which it can drain into the left atrium and into the left ventricle, and hence the blood oxygen saturation of pulmonary artery is more than that of the aorta. So whenever you find that pulmonary artery oxygen saturation is more than that of aorta, you can think of three conditions. One, supracardiac variety of total anomalous pulmonary venous drainage, transposition of great arteries, and toxic being anomaly, or where there is a subpulmonic VSD associated with a double outed right ventricle. Okay, yes, Bensi, go ahead with the pressure data. Are you there?
Yes, sir. Left innominate vein, A14, B14, and mean 13 is raised. Then high SBC, A8, B8, and 6, mean 6 is raised. It's a high normal.
Okay.
Then low SVC, A8 and B8, mean 6 is also normal, borderline.
Okay.
Right atrium, A7, B8, and mean 6 is also borderline. It's normal.
Okay,
Left-
suppose limit was normal. Only thing is that in right atrium here we find that B wave is
A is
slightly
less.
taller than the A wave, but that can happen when large volume of blood is coming to the right atrium. Okay, yes.
Then left atrium, A7, B8, and mean 6.
What does that mean? Looking at the right atrium and the left atrium pressures.
Both are equal, large ASDs.
Yeah, they indicate that unrestricted AST. There is a large AST. Okay, yes, go ahead.
Right ventricle systolic pressure is 40 and diastolic 6. RV systolic pressure is elevated.
Is there a gradient across the tricuspid vein?
No gradients.
No gradient. There is no gradient across the tricuspid vein. Okay, go ahead.
Pulmonary artery systolic is 40 and diastolic 18, mean 26.
Is there a gradient?
Yes, sir.
Where is the gradient? Is there a gradient between RV and PA?
No, sir.
No, sir. No.
No, there is no gradient because the RV systolic pressure and pulmonary artery systolic pressures are
Equal.
equal. Okay, right. Yes.
Then pulmonary artery wedge, A14, B14, and mean 13 is it's normal.
Eh?
It's raised, sir.
It is raised. It is
Raised.
elevated.
Raised.
So, okay. So, PA wedge is A14, B14, and mean is 13. What is the left atrial pressure?
Literally.
What is the left atrial pressure? You read the left atrial pressure.
Yes, sir. Mean 6.
Left atrial pressure is A7, V8, and mean 6. So, why is this? There is a the pulmonary artery pressure is much more than that of the left atrial pressure. What may be the reason?
Because of the TAPVC.
TPVC alone is not enough. You have to give an explanation. Why is that? What is the left innominate vein pressure values?
Obstruction may be present, sir.
Yeah, see, there is a gradient from the left innominate vein to the high SVC, indicating that there must be an obstruction. Only when there is an obstruction, then only there can be a gradient. So the left innominate vein pressure is definitely elevated, and there is a gradient between left innominate vein and the SVC. Here, the pulmonary veins are not draining into the left atrium, but the pulmonary artery wedge pressure reflects actually the pressure in the common pulmonary vein, which actually is draining into the left innominate vein. So actually, the left innominate vein pressure must be the representation of the pulmonary arterial wedge pressure. Okay. Right. Go ahead.
LV systolic pressure is 100 and mean 6. It's normal.
Not mean. What is it? 6?
Diastolic blood pressure is 6.
Mostly it is end diastolic pressure.
End diastolic pressure is 6.
So
And
you have to say that LV systolic 100, end diastolic 6. Yes.
Aortic systolic 100 and aortic diastolic 70 and mean is 82.
Okay. So is that normal?
It's normal.
Can be normal, but for a baby of 3 years, maybe slightly it's elevated, but does not matter. Okay, yes. So what are the abnormalities in the pressure data? What are the abnormalities in the pressure data? Left innominate vein pressure is
Elevated.
Elevated. And there's a gradient from the left innominate vein to the
SVC.
SVC. And
there is
the pressure, the RV systolic pressure is
elevated.
elevated. And pulmonary artery bed pressure also is elevated, which is equal to the pressure in the left innominate vein.
Vein.
Okay.
Yes,
So
that's
what is your, on the basis of the hemodynamic data and oximetry, what is your diagnosis?
There is a supracardiac variety of TAPVC with AST.
Yes, the large AST, that is a AST is a must, otherwise child cannot survive. So there is a unrestricted AST. And there is a obstruction. It is an obstruction. There is an obstruction of the site where the drainage is taking place. So from the left innominate vein to the high SVC, there is an obstruction. That is why the left innominate vein is A14, V14, and vein 13, while high SVC is A8, V8, and vein is 6.
So there is mild pH also, sir.
So there is a mild pH. Well, what is the reason for pH?
Sir, this may be flow related.
Maybe flow related, also may be partly related to obstruction. See, there is a left innominate vein, there is a gradient. The left innominate vein pressure reflects the pulmonary arterial bed pressure. And since there is an elevation of the pulmonary arterial bed pressure, that can also contribute to the
Pulmonary arterial hypertension.
Pulmonary arterial hypertension. And second is the flow related. Large flow into the pulmonary system actually can give rise to elevation of the pulmonary arterial pressure. Okay, now coming to the calculations. When you tell me how will you calculate pulmonary blood flow and systemic blood flow and pulmonary vascular resistance? Tell the formula, that is enough. Pulmonary blood flow, systemic blood flow, and the pulmonary vascular resistance. What is the formula for calculating flow through any region? When we look at the pulmonary blood flow, what is the formula? Oxygen consumption. Oxygen consumption divided by what is the formula to calculate the pulmonary blood flow? What is the formula to calculate the systemic blood flow? And how will you calculate the pulmonary vascular resistance? Any volunteers who would like to discuss what is the formula for in this particular patient?
Sir, for systemic flow, sir, oxygen consumption divided by sir, saturation of aorta minus sir, mixed venous saturation. Okay, right. Yeah. So here, what will be the values? Sir, aorta is aorta 85, and sir, mixed venous. We will calculate, sir. This one, sir, 66 minus 91. Sir, it is 50. 66 minus. Why are you going to 66 minus 91? Sir, no, sir. That you told us, sir, 3 times of SVC, sir. We can. No, but the SVC, they are already shunned as there has been a mixing of the oxygen and blood. Okay, sir. So that is not a mixed venous sample. Sir, so here how to calculate mixed venous, sir? So you have to take a left innominate vein high 64 and IVC 66. You have to take the from these two values. Okay. So sir, it will come around 65. Maybe 64.5, or you want to put it as 65 or 64.5, because the difference is 2 divided by 4, and that can be added to the IVC value. Yes, so 20. Okay. Sir, this is coming 20, sir. Okay, it is 20. Yes. Sir, oxygen consumption is 100. Okay. Sir, 100 by 20 is equal to 5, sir. Sir, oxygen consumption per meter. Yes, oxygen consumption is 100 ml.
But what is the total formula?
Sir, in numerator, I think HB into 1.34 into 10 is there, sir?
Yes.
Sir, that is also there, sir. But sir, we don't take, no, sir. If it is like 1.36 into, sir, hemoglobin percent.
Yes.
Into, sir, the difference. Sir.
What difference?
Sir,
you have to calculate the oxygen consumption 100 ml, that is 100 divided by arterial oxygen difference. You are getting
that
here
is 20, sir.
In percentage, that is 20%.
And sir, in the denominator, sir, we have to do 1.36 into, sir, hemoglobin.
Yes, you have to multiply in order to find out the oxygen consumption in milliliters. You have to multiply oxygen saturation with the hemoglobin, which is 16.6, and the oxygen carrying capacity, which is 1.36, and you have to convert it into liters. For that, you have to multiply with 10. And since it is in percentage, you have to divide it by
100.
And so 10 and 100 can cross each other, so that it becomes 10, and the 10 has to go to the
denominator, sir.
Not denominator, numerator. It goes up. Okay, denominator is one which is below.
Yes, sir.
The one which is above is a numerator. So we have got to go up. So ultimately the formula will be 100 multiplied by 10 divided by
20 into 1.36 into, sir, 16.6.
Yes. So that will be the formula. Okay. So that will give you the systemic blood flow. What will be the pulmonary blood flow? Calculation, say, applying a similar formula.
Yes, sir. Oxygen consumption divided by, sir, pulmonary vein minus pulmonary artery.
Okay.
Saturation.
Okay.
And so here pulmonary vein is 100 minus 88. So it will be, sir, 12.
Okay. Very good. So here the formula is pulmonary arterial wedge, which is 100%. Pulmonary artery is 88. So 12%. 12 multiplied by 16.6 multiplied by 1.36 divided by 10. For that, the 10 will go upstairs to the numerator. So it will be 100 multiplied by 10 divided by 12 multiplied by 16.6 into 1.36. So that will be the pulmonary blood flow. Okay. So what will be the pulmonary vascular resistance? How will you calculate the pulmonary vascular resistance? What is the pulmonary vascular resistance? What is the formula for pulmonary vascular resistance? Pressure drop divided by
flow.
So the pulmonary blood flow we have already calculated. What is the pressure drop? What is the pressure drop?
So mean pulmonary artery pressure is 26.
Yes.
Minus sir, mean sir, pulmonary
usually the formula is pressure drop is the mean pulmonary artery pressure minus
this RA pressure, sir.
No, not RA pressure, LA pressure.
LA pressure.
LA
Yes,
pressure.
Yes,
so it is the mean pulmonary artery pressure minus left atrial pressure. But here the left atrium is not communicating with the pulmonary veins are not draining into left atrium, so we cannot take the left atrial pressure. So instead we have to take the pulmonary arterial wedge pressure. So here the pressure drop is
13.
26 minus 13 divided by pulmonary blood flow. Okay, so that will give you the pulmonary vascular resistance. And if you want to calculate the pulmonary vascular resistance index, then you have to multiply it with the
surface area, body surface area.
Body surface area. Okay. It's a slightly difficult one. Okay, we'll go to the next one. It's a simpler one. This is much more simple. Eknath, you can try now.
First oximetry data.
Okay.
SVC 69%, IVC 72%. Then RA pressure is 71%. RV pressure is 73%.
Not pressure, oximetry.
Saturation. Sorry. Saturation. RV saturation 73%. Pulmonary saturation is 73%. There is no pulmonary artery wedge pressure is 100%. There is a step up from pulmonary artery to the pulmonary artery wedge pressure.
You cannot use
it is normal, no?
No, that is normal.
Okay.
You cannot use the word step up because pulmonary artery wedge we are getting the pulmonary venous blood and it has to be 100%. Okay.
Yes, LV pressure. LV saturation is 99%, and aortic saturation is also 90% normal, sir.
Okay, so there is no step down or step up?
No step up, yes, sir.
In the oximetry data?
Yes, sir.
Okay.
Then pressure data. In our right atrium, AV is 10, V is 6, mean is 6, that is normal, sir.
No, AV is abnormal.
AV is high. Yeah, yes, mean is normal. AV is high, sir.
Yes, AV is elevated because what is the upper limit of AV?
It's rate 3 to 10, sir. 3 to 12.
10 is high, 8.
10 high.
3 to 10. And we can be up to 8. Here it is 10, so it is elevated. Yes?
Yes, sir. So the RV is 100 by 10. So it's increase, sir. RV pressure.
Which one?
RV, sir.
Which pressures are elevated?
Systolic pressure, sir.
What about end-diastolic pressure?
End-diastolic pressure is 10, sir.
Oh, is it elevated or normal?
Sir, it's normal, sir. 4 to 12 is normal, sir.
No. It's only up to 8. Above 8, you have to take it as elevated. While on the left side, it can go up to? What is the? Yes, up to 12. Some people consider 11 definitely, but up to 12 can be taken as normal. So on the right side, it is up to 8, and on the left side, up to 11 or 12. So here it is 10, so it is marginally elevated. Yes?
Yes, sir. Then pulmonary artery, sir. Sir, diastolic, it's abnormal, sir. Pulmonary artery.
Okay.
Then pulmonary artery wedge, sir, A is 7, V is 8. It's a normal, sir.
Okay.
Then LV 107. It's a normal, and aorta is 100 by 7.
Is there a gradient there? Is there a gradient between the left atrium and the left ventricle?
Left atrium.
No, sir.
No, sir.
Because here we could not enter the left atrium. So pulmonary artery wedge pressure can be taken as representative of left atrial pressure. And here the A wave is 7 and the LV end-diastolic pressure also is 7. So there is no gradient across the mitral valve. Okay.
Mitral valve.
Yes. Aortic pressure?
Aortic pressure 170, sir. It's normal.
Okay. Yes. So what is the conclusion from the pressure data?
In pressure data, sir, RV pressure is high, sir. And A wave is high. A wave is also increased, sir.
Okay.
So there is a gradient between artery and pulmonary artery. Sir, pulmonary artery stenosis.
Yes.
Pulmonary valvular stenosis.
That's the pulmonary valve stenosis. Is it a mild stenosis?
Yes, sir. Actually, yes, RV to PA gradient is there, sir.
Yes. Is it a mild stenosis or moderate stenosis or severe stenosis?
Systolic gradient is 75, sir. Yes. So it is severe.
Yes, it is a severe stenosis. Yes. here there is an abnormal equalization of pressure RV, LV, aorta. What is the condition in which you get abnormal equalization of pressures like this? RV systolic, LV systolic, and VS systolic are the aortic systolic are the same.
VSD.
Patrology of Phyto.
Yes, patrology of Phyto is the condition where you get RV, LV, and aortic pressure same. So, do you think that this is patrology of Phyto or only pulmonary stenosis?
So only pulmonary stenosis.
Saturation is 98, sir.
Yes, so there is saturation is normal. So obviously there is no VSD and there is no right left shunt, and so this is only an accidental equalization of systolic pressures between RV, LV, and aorta, and the diagnosis is valvular pulmonary stenosis, severe. Okay, good. Okay, any volunteers to interpret this data? Nikhil, would you like to interpret it, Nikhil?
Sir, there is a high SVC saturation 65, sir.
Okay.
Low SVC is 94. So there is a step up there, sir.
Okay.
Then IVC is 72. Mid RA is 91%. Then RV 92. Pulmonary artery 92. Pulmonary artery wedge pressure is 100%.
Yes.
LA is 91%. Then LV 90. Aorta is 90, sir.
Okay.
So, sir, there is a step up at the low SVC level, sir.
Yes.
So, might be SVC, sinus venosus AST can be there.
Huh? Sinus venosus say all right, low SVC. Sometimes you may mix it up with, well, that's a possibility. But there are many other features here too.
Yes, sir. But there is a aortic. It is a cyanotic congestion, sir.
Yes.
Then.
We just discussed a similar case. So, how is the oxygen saturation?
Sir,
various chambers?
Right side and left side saturation is almost equal, sir.
Equal. So the pressure, the oxygen saturation in the right atrium, right ventricle, left atrium, and left ventricle are practically
equal.
Equal. It's practically same. So
Same.
what is the
Yes,
condition in which you can get similar oxygen saturation?
Anomalous pulmonary venous connection.
It is a total anomalous pulmonary venous drainage that you can get such a oxygen saturation where all the four chambers can have similar oxygen saturation.
Oxygen saturation.
Okay. Yes. So coming on to pressure data.
On pressure data, sir, RA, A 5, V 4, mean is 4. That is the normal.
Okay.
Then RV is 45 by 5. That is also normal, sir. Then no, sir.
Why did you say it's normal? What is the normal upper limit of RV systolic pressure?
Is 20 to 25, sir.
We can go up to 30. Up to 30 can be taken as normal.
Sir.
But here it is 45. So there is
sir.
mild elevation.
Systolic is
systolic
more,
pressure.
sir.
Yes,
sir. Then pulmonary arteries 40 by 20, sir. Mean 28.
Okay.
Then pulmonary artery wedge pressure.
No, you have to give a comment. Is it normal or is it elevated?
It is elevated, sir. Systolic pressure is elevated.
So mild elevation, not a gross elevation. Mild elevation of the pulmonary artery pressure. Upper limit of pulmonary artery systolic pressure is 30.
20.
And the mean, what is the mean pulmonary artery pressure?
28, sir. No, it is more than 25.
Yeah, so usually it's about 20, 22. That will be the when it goes above 20, you should suspect 20 is upper limit of normal for mean pulmonary artery pressure. It has gone above that level. So there is a elevation of the mild elevation of the pulmonary artery pressure. Yes, okay, yes.
Then, sir, pulmonary artery wedge pressure, sir, is.
That's wrong. It is, you can take it as A is equal to V. You take it as 4. A is 4.
A is 4, V is 4, mean 4.5.
Okay.
That is also normal, sir. Then LA is 5, V is 4, mean is 4. That is normal. LV pressure is 110 and in diastolic pressure is 5, sir. That is also normal, sir.
Okay.
Then aortic pressure is 110/70. That is also normal, sir.
Okay. So there is no gradient anywhere.
No, sir.
Okay.
So
what is your diagnosis?
LA and RA pressure are same, sir.
Yes. So that obviously means there is a large
AST is there.
Unrestricted AST. Yes.
Yes, sir. Yes, sir.
So from the oximetry data, it is a total anomalous pulmonary venous drainage. It's a similar one, previous to the one which we have shown, but there is no obstruction of the obstruction for the drainage. Okay, we'll go to the next one. Okay. It's slightly more difficult. Anybody would like to discuss the hemodynamic data? Anybody who would like to volunteer to discuss? I think you should volunteer to discuss so that you become confident to interpret the data in the examination.
Shall I?
Yeah.
Okay, sir. I will. Yes.
What is your name?
First is Eknath, sir. I'm Eknath here.
Eknath, okay, yes.
Okay. So first, sir, oximetry data.
Yes.
SVC high 68, SVC low 67. Then IVC 74, that is normal. RA is 76. RA high, RA low is 83, sir. Step up, sir.
Yeah.
5.
Yeah. What will be the step up that is required to say that there is a step up at RA level? What should be the step up for you to say that there is a significant step up at the RA level?
Sir, for
single sample, multiple samples?
Sir, a single sample, sir,
11, sir.
11, sir, and 10, and a double sample 8.
Some people say that for single sample it should be 10 to 11, and multiple samples either 7, or some people even consider that it should be 10. So I think more than 7 you can take it as multiple samples, more 7 or more, and single sample 10. That's enough. Okay, yes. Here, what is the step up? What is the mixed venous oxygen saturation here?
Mixed venous saturation.
What is the mixed venous oxygen?
Sorry, SVC is 3. Sorry, 1 second, sir. SVC. So shall I take, sir, high or low SVC, sir?
It's better to take always low SVC.
Okay, sir.
means sometimes it may be going into one of the innominate veins. Low SVC is the one where both the innominate veins come together.
Yes, sir. Sir, 3 into SVC low, 3 into 67, sir.
It will be 69 around.
It will be around 69 because 67, 74 minus 67 divided by 4. That will be around 69 would be the
okay, sir.
venous oxygen saturation. Okay.
Then
no, is there a step up?
69 to
yes, sir.
Yes, sir.
Yes,
Step up
sir.
is
Step
there,
up
sir.
is there, sir.
Yes, because actually the real mixing has taken place only at the RV level. So RV is 86%, and the mixed venous oxygen saturation is around 69, so 7%.
17.
No, so not 17. Yeah, from 67 to 86. So plenty of, there is maybe 70. Let us take it as 69.
Yeah.
And then it would be around 16% oxygen saturation elevation, indicating that there is a significant step up at the RA level. Okay, yes.
RV is 86%, sir.
Okay. Is there a step up at RV level?
Not significant.
Not significant. Can the doctor switch off the audio, because some external noise is coming? Okay, yes.
RV 86, pulmonary 86.
What is the explanation that there is a 4% oxygen step up from RA to RV?
4%.
Sometimes when there is a shunt coming to the right atrium, the stream, because of the streaming, sometimes you may get that the oxygen saturation in the RV can be slightly higher than that to the right atrium.
Yes, sir. ASD may be, sir, lower down.
Lower down. So only if the oxygen saturation is more than 5 in multiple samples or more than 7 in single sample, then only you can consider that there can be a left to right shunt coming at the atrial, at the ventricular level. So here it is only 3 or 4 at the most, and so there is no reason for us to suspect that there is a additional VSD, and most likely this step up at the RV level is secondary to the streaming of the blood, which is oxygenated blood joining the right atrium and getting streamed and getting mixed up better in the RV, giving rise to some degree of oxygen saturation elevation at the RV level. So this need not be given importance. Okay, yes.
Sir, pulmonary artery is 86%, sir.
Okay.
That is no step up.
Okay.
Then pulmonary artery weight pressure is 100, sir.
Okay.
LV is 98% and aorta is 98%, sir.
So
here abdomen is, sir, there is step up at the RA level, sir.
Okay, there is a significant step up at the RA level.
RA level, sir.
Okay. So what are the conditions? No, don't go away. What are the conditions in which you can get a step up at RA level?
Sir, step up, sir, in ASD, sir.
ASD.
Left to right.
ASD 1, 2.
Then TAPVC we can get, sir.
Okay, TAPVC, all right, yes. But TAPVC usually the step up will be mostly into the vein to which it drains. So sometimes in the infracardiac variety or the cardiac variety, sometimes you may pick up the step up mostly in the right atrium. Okay, yes. So usually the step up is not at the right atrium, but proximal to the right atrium.
Gerbold's defect.
Gerbold defect, yes, very good, excellent. Who said that?
Ostium primum ASD.
ASD or either any type. Ostium primum.
RSOV to RA.
RSOV to RA, yes.
Fistula, sir.
Yes, RSOV to RA.
Coronary cavernous fistula.
Yeah, coronary cavernous fistula. So these are the 4 conditions that you should suspect when there is a, or maybe partial anomalous pulmonary venous drainage also. So these are the 4 conditions, 5 conditions that you should suspect when the patient is having a RA oxygen step up. ASD is the first one. Gerbold defect where there is a LV to RA shunt, ruptured sinus of Valsalva, partial anomalous pulmonary venous drainage, and coronary cameral fistula into the right atrium. The coronary fistula draining into the right atrium. So these are the conditions you should suspect. Okay, with these things in our mind, we should go to the pressure data. Okay, go ahead, Regna. See, whenever you find an abnormality, you must always think of the differential diagnosis. Don't go for one condition, because when you find a elevation of oxygen saturation at the right atrial level, don't think that it is all ASD. You should always think of the differential diagnosis and then finally conclude what would be the most likely possibility. Okay, right. Yes.
Sir, right atrium, so A wave is 16, sir. and V wave is 18, and mean is 16, sir. It's high, sir.
High. Can this happen in ASD?
SDS, sir, it can happen.
No. ASD usually the pressures are not elevated.
Not yes, sir. The equalization pressure is there. So RA and LS.
RA can be equalized. That's one point. But usually the pressures in the pressure in the right atrium and left atrium are not elevated unless
tricuspid stenosis.
Okay, tricuspid stenosis. Yes, all right. More important than that. RV?
failure.
RV dysfunction. Only when it's RV dysfunction that you can find an RA pressure elevation in the patient with ASD. Otherwise, usually the ASD, the pressures in the right atrium and also in the left atrium, which is equal to right atrial pressure, is not elevated. Because RV being a very compliant structure, the extra volume of blood can be easily accommodated without any significant elevation of the right ventricular pressure, diastolic pressures. So only when the RV starts failing and when the RV and diastolic pressures get elevated, then only there can be a right atrial elevation in a patient with ASD. Okay, so the elevation of right atrial pressure in a patient with a shunt coming to right atrium actually to a large extent rules out ASD. I think there is a noise, external noise coming. Doctor, can you switch off your audio? Mute your audio. Okay, yes. So the right atrial pressure is elevated. Then you have to think of the other possibilities to explain the elevated right atrial pressure. Okay, go ahead.
Then RV is 48/9. It has increased, sir.
Yes.
Then pulmonary artery.
No. You cannot go away from that. What is increased? Is it both the pressures are increased or only systolic pressure is increased?
Only systolic pressure is increased.
9 also is abnormal. There's a mild elevation of
the mild, sir. Yes, mildly.
Is there a gradient?
Yes, sir.
Yes, sir. There is a gradient is there, so 16 and 48. Sir.
Yes, there is a gradient across the
RV.
RR across the tricuspid valve.
Yes.
Because of the RV and diastolic pressure is 9 and RA mean is 16, RA is also 16, indicating that there is a gradient across the tricuspid valve. Okay, yes. So what is the pressure difference across the tricuspid valve which will make it significant?
More than 2.
More than 2.
Sorry, 2.
More than 2. Equal to or more than 2. 1 is normal. Up to 2 is 1 is definitely normal. Up to 2 is can be taken off as normal. 2 above 2 is definitely abnormal. So here it is almost 7. So indicating that there is a significant grade obstruction at the tricuspid valve. Okay, yes, go ahead.
Then pulmonary artery 48, systolic, diastolic is 20. So it has increased.
Yes.
Pulmonary artery. Systolic pressure.
Yes.
The pulmonary artery wedge pressure is 12. Pulmonary artery A is 12 and B is 15. Mean is 30. Mean is 13, sir.
Is it normal?
Slightly increased.
Yes, it is slightly elevated. Yes, very good.
Then LV is 140/12. That is normal, and aortic 140/60.
12 is upper limit of normal. You can, if you want, you can put it as normal. Okay, good. But 140 is also upper limit of normal. 12 also is upper limit of normal. Okay, yes. You should make a comment that it's upper limit of normal, so that the examiner will know that you know what is the range. So all these things are very clear to the examiner. You should not allow the examiner to ask you any question. That's the most important in the examination. So make it very clear. You should exhibit your knowledge, saying that LV is systolic pressure 140 is upper limit of normal, and diastolic pressure 12 is upper limit of normal. Okay, right? Yes.
Aorta, sir, 140/60. It's a normal, sir.
No, it is not normal.
140 is systolic. It's a high, sir, systolic.
Upper limit of normal 60 is. What is
60
the pulse
is lower,
pressure?
sir.
What is the pulse pressure in this patient?
80, sir.
80, sir.
80. Is it normal?
No, sir, it's high, sir.
It's high. Pulse pressure is elevated. What are the conditions in which you get a high pulse pressure? Enumerate few conditions.
Sir, and aortic regurgitation that
Yes.
involved.
Any condition where there is an aortic runoff. You classify into two varieties. One, any condition where there is an aortic runoff, like
aortic regurgitation.
Aortic regurgitation. Tell me 5 or 6 conditions where there can be aortic runoff.
Truncus,
RSOV.
aortic venous fistula, sir.
Which one?
AV fistula.
Oh, okay. There is a large AV fistula very close to the aorta. Yes.
Then
RSOV to RA.
RSOV to RA. RSOV to anywhere. RA, RV. Yes.
Truncus arteriosus, incompetent.
Truncus arteriosus, of course, I agree with you that since here there is a PA and aorta are all seen, truncus arteriosus also can give rise to high volume pulse. Yes, because usually associated with aortic regurgitation, truncal regurgitation. So that we have already mentioned. Aortic runoff means you must be able to say 5, 6 conditions in one go.
PDA.
Which one?
PDA.
PDA. Yes, very good. AP window.
Yes.
Rupture sinus of Valsalva. Large aortopulmonary collaterals. Man-made shunt. All can give rise to. So when you are asked a question about what are the conditions which there can be aortic runoff, you should be able to say aortic regurgitation, tightened nectus arteriosus, AP window, rupture sinus of Valsalva, then the large aortopulmonary collaterals, and also man-made shunt. So these 6 conditions you should be able to say in one stretch. And what is the other group where there can be high wide pulse pressure?
In hyperdynamic circulation.
More than that, you say the conditions associated with peripheral vascular. PVR is brought down. The peripheral, the vascular resistance comes down, resulting in vasodilatation, and there can be a high volume pulse. And high volume pulse were associated with the significant pulse pressure. Conditions? Thyrotoxicosis.
Pregnancy, anemia.
Pregnancy, anemia, even in atherosclerosis. All are conditions where there can be. Which one? Which one? I didn't hear you very well. So these are all conditions where you can get some in Page's disease also you can get high volume pulse. Page's disease. There are all conditions where there can be high volume pulse associated with the wide pulse pressure because of the peripheral vasodilatation. Whenever you are asked a question, you should immediately classify an aortic runoff and second associated with peripheral vasodilatation. Of course, in all conditions associated with aortic runoff, there will be peripheral vasodilatation. Okay, so aortic runoff and other is a pure peripheral vasodilatation, hyperdynamic circulation associated with peripheral vasodilatation, anemia, thyrotoxicosis, very, then atherosclerosis, are all conditions where there can be a high volume pulse associated with the peripheral vasodilatation. Okay, right. Yes. So, what is your diagnosis now? You have found a step up at the.
Just there is in occipit data we have step up at RA level, sir.
RA level. So we have found we have discussed the differential diagnosis of step up at the RA level. So there are 4 or 5 conditions. So yes. please enumerate those 5 conditions and then sir, tell me which one is the one which fits in here the best.
Sir, ASD, THPVC, Gerbaud syndrome, sir. RSO RA and the coronary camera fixture to the RA, sir.
Rather than total anomalous pulmonary venous drainage, you can put it fast anomalous pulmonary venous drainage with intact intrathecal septum. So ASD, intact intrathecal septum with fast anomalous pulmonary venous drainage. What else?
Gerbaud syndrome.
Gerbaud defect, rupture sinus of Valsalva, and coronary
cameral
into the right atrium.
So, right atrium.
So, which one do you think is in, and what is your explanation?
Sir, In
Is it ASD?
pressure that. Sorry, sir.
Is it ASD?
Sir, sir, RARV.
Is this
that
ASD?
AI?
No, sir.
No, sir,
No, sir, actually.
Why it's not ASD?
because
So the
right
RA
atrial pressure
A
is
and
high,
V
sir.
waves are very high, sir.
Yes, VS. Both waves are very high. There's a gradient across the tricuspid valve, and also already the RV and diastolic pressure in a 31-year-old male with ASD, very unusual for the RV to develop dysfunction. So it's very unlikely that this could be. And also PA wedge and right atrial pressure are not equal. So in a large ASD, you expect the right atrial pressure and the PA wedge pressures are to be equal. So there are most likely this is not ASD. Okay, right? Yes. What else? Can this be their body defect?
Sir, RV pressure. No, sorry.
Is their body defect? Is it a small defect or a large defect?
Small defects, sir,
It's a small defect, and so
because there is a gradient.
yes, there is a so. You cannot have this much hemodynamic abnormality, and usually it is a small defect and not a very large shunt. And there we cannot explain the elevated A wave also. You can explain the prominent B wave because there is a jet coming from the left ventricle to the right atrium. So B wave can be prominent in the right atrium, but we cannot explain the prominent and elevated A wave. Okay, yes. Can this be ruptured sinus of Valsalva?
yes, sir. That is more difficult.
Yes. Then how can you explain the prominent A wave?
Yes, sir. In RSOV2 RA, sir, if I remember, sir, most probably, sir, A wave is more prominent.
Why it is more prominent?
Sir, because, sir, here, sir, sir, A wave is more prominent, sir. I have forgotten, sir. Why?
There is a gradient also across the tricuspid valve. So what can be the explanation?
Yeah, sir.
In ruptured sinus.
Yes, sir. Yes, sir. I am telling, sir. Sir, that RSOV2 sir, rupture that is, sir, obstructing to the tricuspid valve because, sir, that sinus is obstructing it.
Yes, because the sinus when it dilates, which sinus is usually which sinus rupture?
This RCC, sir. Right coronary cusp.
No, that's not correct.
Non-coronary.
Yeah, it is the non-coronary which more often ruptures into the right atrium. Of course, rarely the right sinus also can rupture, but more often it is the non-coronary sinus which ruptures into right atrium. It's very close to the tricuspid valve, and when the aneurysm is formed, it can encroach onto the cavity, onto the opening of the tricuspid valve, and there can be a tricuspid valve obstruction. So the tricuspid valve obstruction in this patient is because of the bulging sinus of Valsalva into the tricuspid valve, and that can explain the gradient across the tricuspid valve. And of course, there is a large shunt flowing into the right atrium, thereby elevating the A because of the tricuspid obstruction, and B because of the torrential flow of shunt coming from the ruptured sinus of Valsalva into the right atrium. And because of the sudden increase in the large volume of blood into the right ventricle, there is elevation of the systolic pressure and diastolic pressure. Everything is elevated. Even the pulmonary arterial bed pressure is elevated because of the sudden gush of blood into the left ventricle through the ruptured sinus of Valsalva. So that also has resulted in elevation of the LV and diastolic pressure. Consequently, the pulmonary arterial bed pressure also is elevated. And the white pulse pressure can also be explained by the ruptured sinus of Valsalva. So what is the full diagnosis, Eknath?
Rupture of sinus Valsalva into the right atrium.
Yes. And the sinus of Valsalva aneurysm bulging into the tricuspid valve, resulting in
tricuspid valve obstruction
and a gradient across the tricuspid valve. Okay.
Tricuspid valve.
Okay, good. Okay. Volunteers to discuss the case. There are many others. You should always come forward to discuss cases. Then only you will gain confidence in the examination. Anybody who would like to discuss?
Sir, I will discuss.
No, you have been discussing. If nobody is discussing, I will allow you to discuss. I want others also to discuss. You have become very confident now, so we have to train others to do to your level. Lakshmanan, would you like to discuss? Lakshmanan, are you I would prefer the third years to discuss because they are the people who have to go for the examination. They should be able to interpret better. So first years can actually listen to them and gain adequate knowledge. And second years, if they want, they can discuss. No problems. Lakshmanan, are you a second year or third year student? Lakshmanan Srinivasu. Harish, would you like to discuss? Okay, if there are none, then of course Saroj can discuss. Okay, Saroj, you discuss.
Okay, sir. Sir, first, sir, pressure data. Sir, 25-year-old female patient. Sir, right atrium, A wave is 6 and B wave is 4. Sir, normal.
Okay.
Right ventricle, sir, systolic 50 and diastolic 6. So systolic is high.
Okay.
Pulmonary artery, sir, there is no gradient. Sir, there is no gradient at the tricuspid valve.
Very good.
Sir, now, sir, at the pulmonary artery, sir, no gradient at the pulmonary valve. Sir, diastolic pressure and the mean pulmonary artery pressure is high.
Okay.
Sir, so it is about moderate pulmonary artery hypertension.
Okay.
Sir, then
Moderate borderline. Actually, it is
yes,
50.
sir.
You can take it as even as because the 30 to 50 you can take it as mild.
Okay,
50 to 70 you can take it as moderate, and above 70 you can take it as severe. So 50 I would consider as
mild.
Yes.
Okay, sir. So now wedge pressure, sir, A26 and V25 and mean 25, sir, elevated, sir.
Okay.
So left atria also, sir.
No. So I want to ask you
Yes,
a question. So is the pulmonary artery pressure elevation? What is the pathology there? Is it a passive elevation, or is it there's some degree of reactive pulmonary artery hypertension, or is it obstructive pulmonary artery hypertension?
Sir, it is, sir, due to the sir, left heart. Sir, so it is, sir.
Is it only the pulmonary artery pressure elevation? Is it a passive elevation, or is there a pulmonary vascular reaction also?
Sir, both.
Why did you say that?
Sir, because, sir, that trans pulmonary gradient 7.
Huh? 7? No.
Sir, 1 minute, sir. Sir, pulmonary venous pressure, pulmonary vein, it is 25, and whereas the pulmonary artery pressure, it is 35. Sir, so if we minus, it is 10. Sir, so, sir, transpulmonary gradient more than 7. Sir, so more than 7 means, sir, there is also intrinsic disease of the pulmonary vasculature as well.
Usually it is 7 to 8, slightly elevated. But here, what is the pulmonary arterial diastolic pressure?
Sir, 25.
25. What is the pulmonary artery bed pressure? Mean is 25.
Yes, sir. So that's also 25.
And the pulmonary arterial diastolic pressure and the mean pressure are equal. Mostly there is practically no pulmonary artery vascular reaction. Mostly it is a a passive elevation of the pulmonary artery pressure. So your explanation also is right. There is a borderline elevation of the pulmonary artery pressure, indicating that there could be some degree of a minor degree of pulmonary vascular reaction. It's only very
sir,
minor.
I have a confusion, sir. But for transpulmonary gradient, sir, whether we have to take consideration of mean pulmonary artery pressure and mean of the pulmonary wedge pressure, or sir diastolic, sir?
No, you can take the main pulmonary artery pressure minus the main left atrial pressure is the transpulmonary.
Then, sir, it is coming 10.
That's why I agreed with you that you up to 8 is normal, so 10 is borderline. But you can take another point also. If the pulmonary artery diastolic pressure is equal to that of the pulmonary artery wedge pressure, that usually indicates that the pulmonary artery pressure elevation is secondary to passive elevation of the pulmonary artery pressure. So you can look at both. See, in the human body, everything human may not be able to occur according to textbook. So sometimes you can have the interpretation saying that pulmonary artery diastolic pressure is equal to pulmonary artery wedge pressure, mean pulmonary artery wedge pressure, indicating that practically very little pulmonary vascular reaction. That's all. Okay. Yes. Okay.
Now, sir, left atrial pressure. Sir, A is 26 and B is 24. Sir, A is high and sir, mean also high, significantly high, sir. And sir, left ventricular, sir.
How is that the LA pressure is so high and right atrial pressure is so low, and still you could enter the left atrium?
Sir, I could not understand.
No. See, usually you enter the left atrium through an atrial septal defect.
Yes, sir.
Whenever there is an atrial septal defect, through which you could enter the left atrium, you would expect the right atrial pressure and the left atrial pressure to be near equal to each other because of the large ASD. Here the left atrial pressure is 25 and right atrial pressure is 4. So what is your explanation?
Sir, it will be, sir, patent foramen oval only.
Okay, patent foramen oval only. What is the other possibility?
Or sir, very restrictive ASD.
All right. Okay. Do you think that this could be transseptal puncture
sir,
also?
I think, sir, this one is not done puncture, sir. Pulmonary artery wedge has been taken to the LA pressure.
No, because the catheter has entered the left atrium.
Sir,
so what are the methods by which you can enter the left atrium?
Sir, one is transseptal puncture.
Transseptal puncture.
And if ASD PFO present, then sir. And sir, sometimes, sir,
through the ASD or through the patent foramen oval. These are the three situations where you can enter the left atrium: transseptal puncture, through the ASD, and through the patent foramen oval. Okay, yes. Go ahead.
So now, sir, left ventricle, sir, systolic 120 and diastolic is 5. Sir, there is a significant gradient at the mitral valve level.
Okay, very good.
Now, sir, aorta is 120 by 80 and mean is 95. Sir, normal.
Normal, okay, yes.
So sir,
when the pressure data interpretation?
Sir, it is, sir, severe mitral stenosis.
Yes, the patient is having gradient across the mitral valve, which is significant, severe. Yes. Okay.
Sir, with pulmonary artery hypertension mild.
Yes. Mostly passive elevation of the pulmonary artery pressure, mild pulmonary artery hypertension. Yes. And other pressures are normal.
Sir, others are normal, sir.
Oh, okay. Yes. Then patient underwent a?
Sir, patient underwent a procedure, and after procedure, sir, we are saying, sir, RA is A wave is 5 and V is 4. Okay. So when compared, sir, it has decreased from the previous one. Okay. Marginal. Yes, sir. Now, RV, sir, also, sir, 42 by 6. Pulmonary arteries, sir, hypertension, sir, now it has come mean only 24. So, sir, it's upper limit of the normal.
Okay. No. So pulmonary artery mean pressure is normally it is only up to 20. When it is above 20, you should suspect that something is still there is an elevation of pulmonary artery pressure.
Yes. So left atrial
pulmonary systolic pressure is 40. That also is elevated. Yes. There is some noise coming. Can somebody who is the noise is coming? That doctor can actually. Can you mute so that you are not disturbing the class?
Sir, left atrium.
Yes.
Mean sir now has come from 25 to sir 15.
Very good. So that
Sir, so balloon mitral valvotomy has been done.
Yes, very good. Excellent. So the patient has undergone a procedure which most likely is a balloon mitral valvuloplasty, and which is reflected in the reduction in the left atrial pressure, pulmonary artery pressure, and RV pressure. Okay, right. Yes. So do you think that this is a successful procedure?
Yes, sir. It is successful.
Why?
Sir, once the pressure gradient has to decrease by 50%, sir.
Yes.
Sir, that and sir, MR is not significant because V wave is not more than sir, not significant, sir. Still, sir, it is lower.
So what is the in this patient? How much is the drop in the gradient?
Sir, drop is from 25 to sir 15.
Not 25 to 15. 25 minus 5 is 20. The gradient is only 20.
Oh, yes, sir. Yes, sir. Yes, sir.
And here the gradient has fallen from 20 to 10. From 15.
Yes,
yes, it is 8. So it has fallen more than 50%, indicating that this was a very successful procedure.
PTMC.
Okay. And what has happened to the cardiac output after the procedure?
Yes, sir. Sir, cardiac output.
Did the cardiac output improve, or did it remain the same? What has happened to cardiac output?
It will increase, sir.
Sir, from.
Aganath, did you say it is increased?
Yes, yes, I said.
Why did you say it is increased? Why did you say that there is a cardiac output is increased?
Yes, sir. From seeing the oximetry data in the RA, sir, it has increased, sir. From
no, RA has got no significance. What is the data that you look for to assess the cardiac output in a normal person?
Arterial minus venous.
You will look at the aortic oxygen saturation and pulmonary artery oxygen saturation. And usually, normally, the difference between the aortic oxygen saturation and pulmonary artery oxygen saturation will be around about 25. That indicates normal cardiac output. So in this patient, in the resting state, was there an increase in the cardiac output?
Yes, sir.
Why did you say yes?
No, sir.
No, sir.
I told not for this, sir. I am asking one question. Sir, this pulmonary artery saturation is reflected by sir, RA saturation only. That's why, sir, that should be sir, pulmonary artery only, no?
Yeah. You should look at it, because whenever you are looking at the mixed venous sample in a normal person, the saturation that you should look at is the pulmonary artery saturation.
Yes, sir. Yes.
See, whenever there is no shunt, you should look at the pulmonary artery saturation as the mixed venous oxygen saturation.
Yes, sir.
Whenever there is a shunt,
sir, then sir, we have to go above,
yes.
sir, proximal
to
the shunt.
So if there is a shunt at the pulmonary artery level, you should look at the RV oxygen saturation.
RV, yes, sir.
And if there is a shunt at the RV level, you should look at the
RA.
Right atrium. And if there is a shunt at the right atrial level, then you should calculate the mixed venous oxygen saturation.
Yes, sir.
So that's the way it has to go. So here, the PA oxygen saturation before the procedure and after the procedure is the same, indicating that the resting cardiac output has remained the same. Patient may be able to increase the cardiac output during exercise, but the resting cardiac output is practically it has remained the same, but there has been a very successful procedure, and the gradient across the mitral valve has come down by more than 50%, indicating, and there was no evidence of mitral regurgitation, indicating that there was a very successful procedure.
So here, sir, before and after, it is 26, the difference between the LV, between aorta and pulmonary artery. So, sir, there was no decreased cardiac output even before the procedure.
Yes, the resting cardiac output is all right.
Yes, sir.
It tells us only about the resting cardiac output, but if the patient exercises, it can be different.
Yes.
So resting cardiac output of this patient did not change much after the procedure, but the procedure was extremely successful because the gradient has come down by more than 50%, and also no evidence of any pulmonary mitral regurgitation as evidenced by the V wave remaining maybe near about the upper limit of normal. It has come down from 25 to 15. A wave has come down from 26 to 16. And mean has come down from 25 to 15, all indicating there was a very effective procedure. Okay, very good. I think you did very well, Saroj. Good discussion.
Thanks.
Okay, this is a simple data. Somebody can, without much difficulty, you can discuss. Very simple data. Anybody can discuss. It's very simple.
Shall I discuss?
Sir.
Okay, yes. Okay, go ahead.
Okay, sir. The first oximetry data, sir.
Okay.
High SVC 66%, low SVC 68%, IVC 71%. There is no step up. Then IVC to RA 78%. Step up is there.
Yes. Don't say IVC to RA.
Sorry.
Step up at the RA level.
RA level.
You have to say calculate the mixed venous oxygen saturation and then say the step up. So here, what will be the mixed venous oxygen saturation? Low SVC to IVC is difference is 3, or you take it as 4. So it will be 68 plus 1. So it will be 69. So mixed venous oxygen saturation is around 69.
69.
Okay, right. Yes.
From
69, it has gone to 78%. So
70. It's a step up, sir.
In RA, it is 84. So obviously there is a significant
Step up.
So whenever there is a step up at RA level, what are the conditions that you should suspect?
Sir, first ASD, then Gerbode syndrome.
Yes.
Then RSOE to
Gerbode USD. Yes.
The RSOE to RA.
Okay.
And the coronary camera fistula to the RA.
Yeah. And partial anomalous?
Partial anomalous.
Pulmonary venous drain.
Venous connect.
Intravenous septal. Okay.
Yes.
Okay. Yes.
Then, sir, this RV is 90%, sir.
Okay. Is there a step up at the RV level?
No, sir.
Okay, because the step up is only 4%. So that's not enough to diagnose a step up at the separate step up at the RV level. Okay, yes.
Then pulmonary artery 90%, sir. There is no step up. LA is 99%. LV is 98%.
Okay.
And aorta is 98%. So okay. Here is just step up at RA level, sir. Okay. That is in oximetry data.
Okay.
Then
you have got the LA oxygen saturation. How can you enter the LA? What are the methods by which you can enter the LA?
Sir, LA either by puncture through the foramen oval or ASD, sir.
Okay, ASD, foramen oval or transeptal puncture.
Transeptal puncture.
Okay. Yes.
So in pressure data, sir.
Okay.
RA is 4. RA is 4. VV is 4. Mean is 3.
Okay.
Then RV pressure is systolic 45, diastolic 4. Systolic pressure is high, sir.
Okay.
Then Pulmonary artery pressure 30 and diastolic is 12. So their step down is there, sir.
Yeah. What is the reason?
Maybe pulmonary stenosis, sir.
Yes. 15, you need not consider pulmonary stenosis in a patient with a large AST, the torrential flow. Sometimes a gradient even up to 20 millimeters of mercury across the pulmonary wall has been described. So you can always keep in mind possibility of mild pulmonary stenosis, but this can also be explained by the torrential flow. Okay. Yes. So both the possibilities you should tell in the examination. If you are asked what is the explanation for the gradient, you can always say that it can be in a patient with AST when there is a large flow. There can be sometimes a gradient which is systolic gradient which has been described even up to around 15 to 20 millimeters of mercury. But in every situation where there is a gradient of more than 15 millimeters, you should always keep a possibility of mild pulmonary stenosis. Yes. This I would mainly go for a gradient because of the high pulmonary blood flow. Yes.
Pulmonary artery weight, sir. AV is 4. V is 4.5. Mean is a 4. It's a normal, sir.
And also here, due to some reason, LA pressure is not given, but the RA and the pulmonary artery blood pressures are almost
same, sir.
Same. Okay.
So SD is there.
Yes, yes. So what is your diagnosis?
Atrial septal defect.
Large non-restrictive AST.
Large non-restrictive AST, and the gradient, there is a gradient across the pulmonary valve, which most likely is due to increased flow, but a possibility of mild pulmonary stenosis to be excluded by looking at whether there is any gradient, whether there is any doming of the pulmonary valve. Okay, right, yes. Would you like to calculate the pulmonary vascular resistance index? Pulmonary vascular resistance, can you calculate the pulmonary vascular resistance? What is the pulmonary vascular resistance in this patient? Tell the formula, that's enough.
So formula is so pressure drop divided by the flow.
Yes. What is the pressure drop here?
Sir, mean pulmonary artery pressure is 20, sir.
Yes.
Minus LA pressure, sir.
Which can be pulmonary artery pressure is 4.
4, sir. Sir, 4, sir. Means it's a 16, sir.
16, yes.
Okay.
And pulmonary blood flow formula?
Pulmonary blood flow, sir, oxygen consumption divided by
arteriovenous?
Systemic arterial oxygen content minus mixed venous content.
No, we are looking for not systemic blood flow, we are looking for pulmonary blood flow.
Yes, sir, sorry. Pulmonary venous content minus pulmonary arterial oxygen content.
Yes. So you have to look at the left atrial oxygen saturation, which is 99% minus
pulmonary arterial saturation, sir. 90, sir.
90. So that's 9%. And by applying the formula, you can calculate the systemic blood flow, pulmonary blood flow.
So pulmonary blood flow coming around 21.
21.
Yeah, 190. Sir, per square meter. Sir, for that, what to do, sir? Sir, 190 by 9.
Yes. Let me find out. I also will calculate. So that.
So it is coming 21.
21 liters. So torrential flow. Okay. So it will be arteriovenous oxygen difference. It will be 190 divided by arteriovenous oxygen difference is 9 into 1.36 multiplied by 14, 10. So that would be 190. 9%. The difference is only 9. It's not so 14. Okay. So, no, your calculation is not correct.
Sir, can you tell formula? I just have confusion regarding that divided by 10 or multiplied by 10, sir.
It should be 190 multiplied by 10 divided by 9.
So it is coming around 12, sir.
Yeah, that's right.
Yes, sir.
So
Actually, sir, I did not, at that time, I did not take this hemoglobin and this one.
Oh.
Sir, without that, I was doing, sir.
Oh, yeah, that's it. So it is around 12. So what will be the pulmonary vascular resistance?
So pulmonary artery pressure is 20.
Yes.
And sir, left atrial pressure 4.
Yes.
Divided by 12.
Yes.
So sir, it is coming 16 by 12.
Oh. So that will be 1.3.
3.
Yes, it is about 1.3. Is it normal or abnormal?
Yes, sir. Normal, sir.
It's normal. So pulmonary vascular.
Up to 3.
So in patients with ASD, even with a perfectly normal pulmonary vascular resistance, they can have elevated pulmonary artery pressure because of the increased flow. So here it's because of the very significantly increased flow, this patient has got elevated pulmonary artery pressure. And what will be the pulmonary vascular resistance index?
So now we will multiply it by this one, 1.7.
1.7, 1.2.
To 1.2, sir. Yes. 1.2.
So that will be around 1.5.
Yes, sir.
Okay, very good. So now we go to another one, which is now let me take another one. Not this one. We'll have another one. Okay. Can you see my screen?
Yes, sir.
Yes,
okay.
Sir.
Look at this Cath data. This is slightly more difficult. Yes.
Sir, SVC oximetry data, sir.
Okay. What is your name?
Nikhil, sir.
Nikhil. Okay, very good, Nikhil. Yes.
Sir, SVC is 59%. High SVC is 59%. Low SVC is 60%, sir. IVC is 60%. RA is IVC is 64%. Right atrium 64%. Right ventricle is 82%. Sir, there is a step up between the right atrium to right ventricle, sir.
Okay.
Then pulmonary artery is 82%. Pulmonary vein is 100%. Then left atrium is 85%. Left ventricle is 82%. Aorta is 82%. Yes. So there is a drop in the left atrium saturation, sir.
Okay.
And aorta is also 82%.
Saturation of the left atrium is significantly lower compared to pulmonary venous.
Venous saturation, sir.
Okay.
And aorta is 82. So this is a cyanotic heart disease condition, sir.
Okay.
Sir, RV, LV, AO, pulmonary artery, all 4 same, sir.
Yeah. So what does that mean? RV, LV, pulmonary artery, all same. RV, RV, LV.
Sir, RV, LV, PA and AO.
No, P and A, all are same. What does that mean?
So either sir, there is a big
large VSD is there.
No. Transposition also.
No. What are the hemodynamic conditions which can result in cyanotic angle heart disease? Eknath? No, sorry, Eknath. Nikhil.
Sir, TAPVC, transposition of great artery.
Put it as a group.
Sir, admixture physiology.
Admixture physiology. It is an admixture physiology which is occurring prior to the right atrium that you will get oxygen saturation in all the 4 chambers the same.
Yes, sir.
So whenever you find that there's an oxygen saturation is the same in all the 4 chambers, you should always think of the admixture lesion. Either it could be either a total anomalous pulmonary venous drainage, or it could be a single atrium.
Okay.
So you must always suspect the possibility of, or it could be tricuspid atresia, where the whole the drainage from the right atrium can drain into the left atrium, and subsequently it can go both to the right ventricle and the left ventricle, and then thereby it can go to the pulmonary artery and to the aorta. So whenever there is a equalization of oxygen saturation in the right atrium, in the right ventricle, the left ventricle, pulmonary artery, and the aorta, you should always think of the possibility of an admixture lesion also.
Admixture. Yes, sir.
Yes.
Then, sir, pressure data, sir.
Well, before that, you can also look at, there's a catheter course is given there. So can you read the catheter course?
A course, yes, sir. IVC, right atrium, then left atrium, then pulmonary. Sir, that pulmonary vein and
yes, it has gone from the left atrium. It has gone to the pulmonary vein, and from IVC it has gone to SVC.
Okay. Then left ventricle, right ventricle, and pulmonary artery.
So, what is the looking at the catheter course? What is your diagnosis?
Either ASD or PFO or septostomy.
Okay, that is there. It has easily gone to the left side. So there is most likely there is either a septal puncture, whatever it is. So cyanotic angle heart disease, we don't do a septal puncture, so it could be an ASD. Okay, anything else? Usually, where does the catheter go from right atrium? Normally,
what, sir?
Normally, the catheter
right atrium to right ventricle.
Right atrium to the
right ventricle.
Right ventricle. So here, the catheter has not gone from right atrium to right ventricle. It has gone to left atrium, left ventricle to right ventricle. So,
yes, sir.
What do you think it is?
So, tricuspid atresia.
Yes, you should think about the possibility of tricuspid
atresia.
Atresia, looking at the catheter course, because it is from IVC to the right atrium, to the left atrium, to the LV, and then to RV. So it did not enter the RV from RA to RV, but it just entered the RV from right atrium, left atrium, LV, and to the right ventricle.
Right.
So whenever such a catheter course is given, you should always suspect whether it could be
tricuspid atresia.
And then you should look at the oximetry data once again to confirm whether this catheter course fits in with the oximetry data. So let's go back to oximetry data. So let us look at whether it fits in.
Okay, sir. Then IVC was 64, RA 64. Then from RA, it went to the LA. So LA was 85%, sir.
LA is desaturated because it is getting blood from right atrium as well as blood coming from the
blood coming from pulmonary vein.
Pulmonary veins, yes.
Yes, sir, it fits, sir, because sir, RA and RVs are big difference, whereas RV and LV don't have much difference.
Yes, because the RV and the LV are getting the same oxygen saturation, indicating that there is the RV and LV, they are sharing the blood. So already the admixture has taken place in the in tricuspid atresia through in the left side chambers, LV and RV, LV and LA, and the blood is flowing from LV to right ventricle, and the oxygen saturation of LV and RV must be the same. So the oximetry data is not against the diagnosis of
tricuspid atresia.
Yes. So let's look at the hemodynamic pressure data.
In pressure data, sir, RA is 8, V is weight, mean is 7, so that is normal, sir.
Okay.
Then RV 60 systolic and 7 is diastolic, sir. So RV systolic pressure is elevated, sir.
Okay, why it is elevated?
Left to right.
Yes, there is a significant left to right shunt. There may be large BSD, and so the pressure in the RV is also significantly elevated because of the large BSD. Yeah, okay, yes.
Yes, sir. Then pulmonary artery systolic pressure 25 and diastolic is 8, sir, and mean is 13. So that is also normal, sir.
Oh, there's a gradient across the.
What, sir?
There is a gradient across the.
Yes, sir. There is systolic RV systolic is 60, sir. Pulmonary artery systolic is 25, sir. So there is significant drop in the systolic pressure, sir.
Yes.
Yes, sir. Then left atrium A wave 8, V wave 8, and this is mean is 7. So there is RA and LA pressure are equal, sir.
Okay.
So there is a non-restrictive ASD is there, sir.
Very good.
Then pulmonary vein A wave 8, V wave 8, and 7, that is normal, sir.
Very good.
Then LV systolic 150 and diastolic is 7, sir. So there is no gradient between LA and V.
150 is 100%, normal. Okay.
Yes, sir. Oh. And aorta is 100 systolic and 70 is diastolic.
Okay.
So
is the ASD large or is it restricted? Restricted ASD? Sorry, VSD, is it large or restricted VSD? VSD.
So there is
restricted
VSD,
sir,
because there is 90-degree gradient between the LV and RV, sir.
Not 90, 100. It is LV is 100 and RV is 60. So there is a significant.
40.
So it obviously means that there is the VSD is not non-restrictive. It's a restrictive VSD. So you should mention that also. There is a restrictive VSD across the ventricular septum. There's a restrictive VSD. So what is your full diagnosis? Full diagnosis.
Sir, there is a tricuspid atresia with non-restrictive ASD and restrictive VSD,
ASD and restrictive
VSD, sir.
With a mild pulmonary
stenosis.
Mild pulmonary stenosis, yes, sir.
That's a full diagnosis. So this is a case of tricuspid atresia, non-restrictive ASD, restrictive VSD with mild pulmonary stenosis. Okay, I think it has become all right. We'll stop at this level. Next class, what would you like to have? Is a case discussion?
Yes, sir, case discussion.
Okay, we can have a case discussion. Will anybody any one of you will it be possible for you to bring one case? Otherwise, I will bring one. I can bring one. If somebody, one of you is having a case, you can bring that case. We can discuss that. Bensi, where are you working?
Random, sir.
Random Medical College.
No, sir. Kim's Random.
Okay, so you can bring one case. If possible, you bring a case. Otherwise, I will bring a case. So next week we'll have a case discussion. I think we must alternate case discussion with the other discussions, so that case discussion is the most important thing, which will help you to clear the examination. But along with that, you should have a spot test, and which will ultimately help you in the practical, in the oral examination also. Okay, I think the discussion was very good. All of you did extremely well, and Nikhil, I think in the last case you discussed very well. In general, all of you did extremely well. Good. So next class we'll have a case discussion. Okay, thank you. Good night.
Okay, thank you, sir.
Thank you, sir. Good night.
Good
So
night.
from here now I'm ending this meeting.
Okay, thank you. You can stop.
Thank you. Yeah,
Thank you.
sure.
Thank you.